Hello and welcome to Checking the Vitals, a podcast powered by Specialty Care. I'm Todd Schlosser, and joining me today is Dr. Ziad Hage from Novant Health in Charlotte, North Carolina. Dr. Hage is a board-certified skull-based neurosurgeon specializing in cerebrovascular and endovascular approaches. In this episode, we talk about how his family inspired him to enter the healthcare space, what exactly led him to the surgical space, his transition from Lebanon to the United States after medical school, and how a conversation with a friend made him change his surgical focus from plastics to neurosurgery. Enjoy the conversation. Dr. Hage, thank you so much for taking the time to join us here on Checking the Vitals. I really appreciate it. I like to start off the podcast with a similar question to everybody, and that is simply, what is it that helped you develop a passion for working in healthcare in general?
Well, Todd, thank you so much for having me. It's a pleasure and an honor to be here. Really, the story starts when I was young. My father is currently a retired medical oncologist, and my uncle, his brother, is a still practicing radiation oncologist. So I was surrounded by physicians growing up, and really the love of medicine, I just grew up in it. It just came to me by watching my father and my uncle treat patients. I sometimes used to actually go with my father to home consultations, or whenever he was administering chemotherapy, I would sometimes be with him in clinic. I also joined my uncle later on and helped him out a little bit with a few projects. So very early on, I was exposed to medicine, and I quickly knew that that's what I wanted to be. And I also knew early on that I wanted to be a little different than what they did. They're more medical doctors, and they treat patients with medicine. I knew I wanted to be more hands-on, and I wanted to be a surgeon. So that came on very early on in my, childhood and later years.
So are we talking, high school, or I'm not actually sure what you would call it where you were growing up. Is it high school in Lebanon where you were growing up?
Yeah, I grew up in Lebanon. The country passed through tumultuous times, and there were times where there was war and times when things were calm. And during the war, I lived in France, in Paris, with my family. And when things calmed down, I came back to Lebanon in the very early 90s. And then I, lived in Lebanon until the time I came to the United States in 2006. So, school and then university, I did in Lebanon. And those were the times when I was pretty much with my dad.
I'd imagine he was a strong mentor for you and your uncle. I mean, it's sort of medicine, or, healthcare is sort of a family business in your family, it seems like. So you came by the passion for it, honestly, it sounds like.
Exactly.
And then you decided that, okay, I want to actually pursue this, but from a surgical side. Do you know what it was that made you say, I'm more interested in fixing things with my hands than fixing things with medicine?
Good question. I feel like in anything I do, not only in medicine, but I'm very hands-on with building things or engineering things at home, like the handyman at home or things like that. I used to I still do actually have a hobby of flying RC planes and playing with cars and things like that. So I build things with my hands. I've always had that, and maybe that's what really kind of was a big component of why I wanted to also help people with my hands in medicine by being a surgeon. I think that probably had a big impact on me.
Yeah. So you're sort of always been a tinkerer, it sounds like. I have talked to a good number of surgeons who have said that they like the immediacy of surgery, because a lot of times, not in all cases, but a lot of times someone will come in and you'll do surgery and their progress is so much faster than, like a medical or medicine approach. And I think that that's an interesting way to look at it as well. Yeah.
That's a good thought. But when you're young, you don't have enough knowledge to understand that usually. So at the very beginning, I think it was maybe a different reason. Now, there's a few things that we treat in what I do in neurosurgery that surgery will not necessarily fix the problem immediately. But you're absolutely right that usually surgery is a quicker fix than certain medications most of the time.
Yeah, but not all the time.
Yeah, exactly. It's a combination of many things, I think.
So when you decided, okay, I want to focus on surgery, and then you wanted to practice in America, so you wanted to come to America. How did someone who was in your position, I'd imagine at that point you were a medical school graduate
Correct.
overseas, and then you were applying to come to the state. How does that process work?
How does it work? Excellent. So I did my medical school at the American University of Beirut in Beirut, Lebanon, which is one of the top schools for medicine in Lebanon and the Middle East. And as its name, clearly says, it's an American university. So all the education we got was in English, and all the professors that were teaching medical school classes were teaching it, were either educated in the United States or had some sort of formation in the United States. And then ultimately, when we started doing our rotations in the last 2 years of medical school, clinical rotations at the medical center, which is American University of Beirut, AUBMC Medical Center, the rule was most of the physicians had to be board certified in the United States to work at this hospital in Lebanon.
Oh, wow. Okay.
So we're very heavily exposed to the American way of treating patients, American medicine. And to be honest with you, probably 45 to 50% of my class ended up going to the United States for residency training. So it was a common thing.
Okay.
And everybody knows that training in the United States is the best training you can have, be it in surgery or any other medical specialty. So I kind of had that from being formed at my university, and also knowing that if you really want to have the best training, you got to come to this country.
Yeah. Let me ask that. So I'd imagine you had decided neurosurgery was for you before you started applying to come to the U.S. Is that how that works?
So that's a nice story. So as I was finishing my medical school, I had a good idea that I wanted to come to the U.S. Again, the university guides you, informs you very early on in order to facilitate coming to the U.S. So everybody knows what types of exams, the United States medical licensing examinations, USMLE exams that you have to sit for in order to come to the U.S. Everybody knows what they are. The testing centers are in Lebanon for those that you can do in a different country. So, I mean, we were formed from the get-go to do that if this is what we wanted to do. In terms of whether or not I wanted to do neurosurgery, funny story that, not a lot of people know, but a lot of people will now. At the beginning, I was leaning towards plastic surgery, maybe, honestly.
Okay.
So I knew I wanted to be in a surgical specialty. I was leaning towards plastic surgery. Neuro was an option, but it wasn't as much as plastics. I was kind of still lost in translation a little bit. So what I did is last couple of years in the 6th and 7th years, which is medical 3 and medical 4 year, I started applying for the tests, the step 1 exam. This is what it's called, the step 2, the part that you can do in Lebanon. And then I got ready to travel to the United States to sit for the step 2 exam that you can only take in the United States. Because this is the test where you are dealing with quote unquote patients that are pretty much actors that play the role of patients, and you're basically graded as to how do you approach these patients. And so that's why this test is only given in the US, and there's I think only 5 states in the US that give the exam.
You had to come to a specific testing location. It wasn't just somewhere in the US. You had to come to I think it was Chicago. Is that where you ended up?
You're absolutely right. Yes. Yeah. So of all the states that gave it, which were 5 of them, I think it was LA, Chicago, Texas, and 2 other states. Chicago I chose is because one of the people I graduated from medical school with, who's a very good friend of mine, Dr. Adele, who's actually same as me, practicing endovascular, open vascular neurosurgeon in Michigan, was already in the United States. He had kind of been accepted in training a couple of years before me, and I knew he was there, and so he was gracious enough to shelter me in his house and guide me and help me out a little bit when I was sitting for the exam. So I chose Chicago for convenience because he was there for advice. And so I end up, coming here, I sat for the exam, and this is how neurosurgery happened. So as I was at his house preparing to sit for the exam, which was a few days later, he told me, listen, I know that you're thinking about plastic surgery. Would you consider neurosurgery? Because I was doing a research position. I was a postdoctoral research fellow at the Northwestern University, and I just got accepted into the training program at Northwestern. And so my position is vacant, and my mentor, who's an outstanding neurosurgeon, Dr. Bernard Bendock, is looking for somebody to replace me. And so you've got an open position. I could put you in touch with him, and you can meet with him and see if he likes you and he wants to give you the job. I understand it's not plastic surgery, but you could, start working in a surgical specialty, maybe do joint projects between plastic and neuro, and put your foot in through the door and see what happens. And I debated and I thought about it, and I thought it was an offer I could not miss. I couldn't say no to, especially after I met Professor Bendock, Bernard Bendock.
Oh, yeah.
He's currently the chairman of neurosurgery at the Mayo Clinic in Arizona, and a good friend of mine. And when I met him, I felt like this was the guy that I wanted to be working with. I wanted him to be my mentor. And so pretty much I give the credit to him and the chairman of neurosurgery at Northwestern at the time, Professor Hunt Bajer. Both of them instilled neurosurgery in me, and I fell in love with it so much that I would think about the fact that I wanted to do plastic surgery, and I'd be like, how could I even think about doing plastic surgery when I love neuro so much? So it was funny, but that's the real story behind it.
That's very interesting. I mean, most people, they have a passion for one thing, like they do their rotations in medical school and they say, cardiology wasn't for me, but, going inside the skull was a rush. I have to do that.
Exactly.
It's just interesting that for you, it was, you met a mentor and you were like, oh, I want to follow in this person's footsteps. And that to me is very interesting, especially because it turns out that you can't see it going any differently now. And even though it was a different path altogether, that's super interesting. So you sat for that test. Obviously, you did well, right?
Yeah, absolutely.
And then you eventually, I guess, made the move over here. And where did you settle as far as your residency, your neurosurgical residency?
So going back a little bit, I want to emphasize one point that we had talked about, you and I, offline before we started the video. Coming to the United States to train in either a surgical specialty or a medical specialty as a foreign medical graduate, or FMG, is exceedingly difficult because you're competing with US graduates. And I know the numbers for neurosurgery because ultimately I joined the training program, but the acceptance rate for a foreign medical graduate from a different country, any country, could be France, Brazil, whatever, coming to the United States to apply for training, that's what residency means. It's training in a specialty. Yeah. After you graduate as a medical doctor with an MD degree, the acceptance rate was around 8%. 8%. So of all the people, the thousands of people that apply to this country for the neurosurgical specialty, they'll only take 8%. And that number was, I think I checked it more than 5 years ago. I mean, it could have been, it's exceedingly difficult to get in because number one, you're coming to this country, you have absolutely no contacts. Nobody can vouch for you. You're not a medical student. You didn't do your medical school at, I don't know, in Chicago or in Michigan, one of the medical schools, and your preceptors, that watched you rotate with them can write you a letter, and the residency program is going to recognize those names because they're from this country. Imagine me coming from a different country with a doctor that wrote me a letter of recommendation. I mean, the physician that's looking at it here has no idea who that person is and how solid the program is. So that's why it's so difficult. But so, yeah, I mean, I think life is you definitely have to work hard, do very well at the test. There's always a part of luck. And I was lucky enough to come at a time when this position was vacant with an outstanding mentor. I think I was definitely lucky. So, God was watching over me definitely at the time. And so I had to make sure I did excellent and had very highly competitive scores, because that's what you need to do to get in with so high stakes and the percentages being against you. So I did very well with the grades, and I worked hard with Dr. Bendock for 2 years. I did the research fellowship. What he did is he helped me build my CV, my resume, in order for me to be competitive enough to compete with American graduates. So American graduates will graduate from medical school and almost immediately get into a residency program. Compare that to me, who did not have the competitive edge at the end at that time. So even though I graduated from medical school, I still had to do 2 years of research to accumulate enough kind of research and to earn letters of recommendation that then made me competitive enough to get in. So after medical school, I did 2 years of research, and it was an amazing time. I published a lot, got my name out there. People started reading my articles alongside with Dr. Bendock. And then when came the time for him to write me letters of recommendation, he did. Dr. Bajer did. Dr. Awad did. Big names in neurosurgery in this country, and that's what got me in, is the good letters of recommendation.
I mean, I understand that you were doing work during that time. You were working in the medical field during that time, the research years, right? But it seems like that was as much like mentoring and learning as much as it was sort of building a contact network of people who sort of knew you and would vouch for you to help get you into a established residency program.
A highly competitive residency program. You got it right. And so to answer your question, when the time came for me to start looking for positions for training, there's a process that's well known. It's called the matching process, that's how medical graduates apply for medical graduates apply for residency programs around the country. And I applied to many positions around the country through the match, and I ended up being at the University of Illinois in Chicago with Professor Fadi Charbel, who's an outstanding neurosurgeon and a vascular neurosurgeon. And he trained me for 7 years, and those were amazing times. A lot of what I can do now, I owe it to him.
I imagine a lot of what you specialize in and what you learn in that 7 years of residency, which I believe is one of the, if not the longest residency as far as the longest,
you're right.
You learn all of that just because you're getting so much hands-on time, especially later in residency, right?
You got it right.
Yeah.
So it's 7 years of neurosurgery residency to just become a general neurosurgeon.
Yeah.
And then if you want to do a subspecialty to become a spine surgeon, a functional neurosurgeon, tumor surgeon, or like me, an endovascular, open vascular neurosurgeon, there's additional training. So on top of the 7, I then did 2 years of, 2 years of endovascular, open vascular, and skull base to become what I am right now. So
that's amazing. So your training period, and I realize that saying training period when you're talking to a doctor is a little bit of a misnomer because you're never not learning new things as a doctor.
Correct.
But I would say formal training period ended 9 years after you started residency, because you got the 7 years of residency and then the 2 of the post-residency fellowship, right? Of the endovascular and vascular fellowship.
I did, after graduating, I did 2 years of research. Then I got into residency for 7 years.
Yeah.
And then I did my fellowship. So it was a total of 10 plus years.
Oh, wow. That's quite a commitment to make to furthering your studies. But so let me ask this, and I love asking this, and people actually go in and do a fellowship, or I should say doctors go in and do a fellowship. What was it about endovascular and just vascular neurosurgery that drew you to want to learn even more about
it? Exactly. So, when I joined Dr. Bendock at Northwestern for the research fellowship, he is a vascular, endovascular neurosurgeon. The chairman of the department where I worked at the time, Professor Bajer, who's the chairman of neurosurgery at UT Southwestern right now, was also a vascular neurosurgeon. So it just shows you how important is the influence of your mentors on you. Yeah. So these were 2 huge vascular neurosurgeons that I was being immersed with and working with, and I just fell in love with blood vessels of the brain. And to me, it was probably the most meticulous and difficult specialty within neurosurgery. That's, in my mind, probably one of the most difficult surgical specialties. I really wanted to do the most meticulous and difficult type of surgeries, and I fell in love with those diseases, the vessels of the brain, and so nowadays, if you want to be a vascular neurosurgeon that treats vessels of the neck and brain, you have to be able to be dual trained. So not only do you do the surgeries with open methods where you cut the head open or the neck open to do the surgery, but you do it from within. So that's what endovascular means. You use
Yeah.
a tube through the patient's vessels. So I'm dual trained to do both. And I treat conditions at the base of the skull, which are usually the most challenging and intricate. And so I owe that to them and the chairman of neurosurgery in Chicago, Dr. Charbel, who's also a vascular neurosurgeon. So wherever I went, it was heavily vascular, and so I just fell in love with it.
That's awesome. So can I ask now, what are some common reasons someone would seek out your services? So why would a patient come see you?
So diseases that I treat include everything under the sun related to blood vessels of the brain. So starting from the neck, I do treatment of carotid disease. I could do it by open method, which is called carotid endarterectomy, or through the groin by doing a stent. Sometimes we do it through the arm as well, most of the time these days. So I can do the endarterectomy or the stenting procedure. Sometimes I go below the neck if there's a subclavian problem. So anything in the blood vessels from the upper chest up into the neck area and then into the brain I do, okay? And then anything that would relate to brain aneurysms, brain AVMs, or what we call arteriovenous malformations, arteriovenous fistula, those are basically abnormal tangles of blood vessels in the brain. I treat those either by open surgery or by putting glue in them. That's what we call endovascular embolization. I can also treat them with focused radiation with my radiation oncology team members. That's what we call stereotactic radiosurgery.
Yeah.
Moya disease is one of the big things I do. It's a rare condition that affects blood vessels of the brain, where the blood vessels shrivel down and narrow down to the point where they ultimately shut down and the brain is starving for blood. Oh. And so what I do is, like people do bypass for the heart, I do bypass for the brain. And only a few people around the country, only a few centers can do it. And so I do that. And again, I owe that to my mentor, Dr. Charbel. He's one of the top bypass surgeons in the country and the world. So I learned that from him, learned from the best.
That's amazing. I've honestly never heard of, obviously heard of bypass heart surgery, never heard of the bypass brain surgery. That's very, very interesting.
So those are things related to blood vessels. I must have mentioned, I think already, brain aneurysms. Yeah, I treat those with open brain surgery, or I could do it with coiling or stent coiling. I do all those procedures. Any type of brain tumor, again, those at the skull base, which are the more difficult ones I do. I do the pituitary tumors by going through the nose. I used to do more spine. My vascular practice is so busy that I'm doing much less spine. I give that to my spine colleagues.
Yeah. Well, I mean, with your focus being the vascular stuff, I'd imagine that's what you want to focus on. Especially if you have too much to handle, you're going to pass the spine stuff off to people who maybe went to a spine fellowship,
Absolutely.
So that makes sense. Let me ask this though. So, and I largely because you've been in the medical world or realm, right, for at least, especially neurosurgery, what, 15, 20 years at this point? Including your residency and stuff, right?
Correct. So, yes. Since 06, 15 years. Yeah.
Okay. So 15 years. So how has the treatment of, say, like an aneurysm, how has that changed over the 15 years that you've been in the neurosurgical space?
Yeah, absolutely.
Whether it be techniques or, instruments used or things like that.
So for the open brain surgery side, that's the much older type of treatment that was available for decades. And so that part of the field has not evolved much. Now we could have new instruments to do the surgery, but the technique by itself is overall standard, I would say. The area that has seen substantial improvement and developments over the year in terms of technique and instruments available is the endovascular technique, which is pretty much born in the early 90s. So it's relatively new compared to the open surgical specialty that's been there for decades. Yeah. And so every year we see new catheters that are tubes that allow us to do the procedure by delivering the instruments, new types of coils, new types of stents, that basically are developed and that we use. And the other area that I treat that I haven't mentioned is stroke, because I'm an endovascular neurosurgeon. I treat stroke. So if somebody has a blocked blood vessel, I can go up through the blood vessels, either from the groin or the arm, to the area of blockage, and we open it. And so the area of stroke treatment, endovascular stroke treatment, has seen substantial developments as well. in terms of the types of devices we use to suck the clot out. That's what we call aspiration devices. It's pretty much like a vacuum that vacuums the clot and reopen the vessel, or the stent retrievers, which are metal stents that we put to drag that clot out of the vessel. So, I mean, we've seen huge developments and improvements, and the field of stroke has substantially changed. I mean, when I was training in neurosurgery at the very beginning in the late 2000s, if somebody has a stroke, you were like, too bad. I mean, there's nothing much we can do. The brain is gonna die off, or the stroke happened. There's nothing you can do. Right now, somebody comes in with a stroke, based on certain criteria, you're able to save them.
Yeah, and I'd imagine that, and this is an area that, unfortunately, because of a family member that happened to one of my family members, and it's just, we were in that situation because it was years ago. There wasn't much we could do. It was that whole thing.
Absolutely.
Exactly what you said.
And that's sad.
No, it absolutely is. It's one of the reasons I wanted to start the podcast, quite frankly, because I'm interested in people who do what you do, who like literally push forward innovation to make that conversation that we had with that doctor not so dire, right? Because now,
absolutely.
And I understand, especially with strokes, they can sort of happen anywhere in the brain, and where it happens in the brain can still sort of dictate whether you can or can't do things. Is that still the case? I'd imagine it is, but
you're absolutely right. So, and the indications for treatment are expanding substantially. At the very beginning of treating strokes, we're only doing a very few cases that were very select, and now the selection criteria is broadening. The amount of time we allow for a stroke to have happened to treat is broadening. At the very beginning, we wouldn't treat anybody beyond 6 hours, then it pushed out to 12. Now we're treating people 24 plus hours after having had the stroke, which is a lot. We're also going further down deep in the brain. At the very beginning, we would only treat strokes that were blocking vessels very close to us, as opposed to farther down. We call that proximal occlusions. But as our instruments have allowed us to go deeper in a safer way, we're now following clots and strokes deeper in the brain and able to do things we weren't able to do last year or the year before. So definitely, and there's other technologies that we're using. For example, bleeding in the brain. Sometimes people can have bleeding in the brain either because they had high blood pressure that is not well controlled, and they have what we call intracranial hemorrhage because of high blood pressure. Basically, the vessel gets fragile because it's subjected to high pressure all the time, and it just bursts open, and people have a bleeding in the brain. And so, until recently, you'd have to do major brain surgery to do it. And I was the first in North Carolina to do this minimally invasive procedure where I basically went through a tiny little hole in the forehead with a tiny little cut in the skin, through a path inside the brain using a camera that was the diameter of a pencil to suck out the entire clot. And I removed 96% of it using a brand new device that had just been developed. And the patient did well. And since then, we've been using it. So, I mean, there's a lot of things that, you have to be willing to try new devices, obviously, that the FDA has approved, or sometimes you can get an exemption to do that, but just to help patients. And you have to be cutting edge all the time.
Yeah, and that's sort of what I meant with the, you never really end your training, right? Because you're always learning new things. And I actually am interested in that as well. So when a medical device manufacturer comes out with a new instrument or a new scope or whatever you're looking to incorporate into your practice, how do you practice on that? How do you learn that new technique with that new scope or instrument or whatever it is?
So if it is a new device that needs some sort of practicing, usually the vendor will offer labs at your own, whenever you have time, you'll practice a certain type of new technique with mentors that have helped develop the instrumentation or the technique. So you'll have to go through courses. Sometimes the FDA will mandate that before you can do a certain type of stent placement or things like that. You have to be proctored for the first, assuming 5 or 8 times. And then once the proctor signs off that you're, comfortable enough doing it, then you can do it. So there's a lot of mechanisms, either in the lab or by a proctor or both, really. So that's how you do it.
So I'd imagine that is sort of always happening, but is it on you as the surgeon to want to incorporate that new technology, new technique in your practice?
Yeah, I mean, most of the time it has to be self-driven because it's very easy to be comfortable with what you already know how to do, and not wanting to go into an area that you feel like you may not be as comfortable, or using instruments that are new. But I think that's the only way to help patients, is to keep following the progress and getting comfortable with that progress, because medicine is a ever evolving discipline, especially with what I do. And there's so much developments that, especially in stroke, for example, I mean, imagine getting stuck on one type of catheter or retriever device that was there 5 years ago. I mean, right now they're obsolete. Things we used 5 years ago, some of them are obsolete. So if you're not willing to improve or try new things, your treatments would be obsolete.
Yeah, no, I've talked to a few neurosurgeons who are on this sort of front line of exactly what happened in my family, and I fully believe that if it happened this year instead of 4 years ago, he would probably still be with us. You know, it's sort of
Very
that
possible.
sort of thing. So like and that's one of the things I love about this podcast, because it's, for me, it was a stroke in my family, right? But for other people, it's heart disease, or it's, you know, XYZ. So I love talking to people like you who are literally on the front line and are not, I don't want to say complacent, because I understand physician burnout is very real, but you know, I'm so enamored with surgeons or physicians on any level, really, who have been through years and years and years of school, and then when they could rest on their laurels and just sit with what they've learned, they choose not to, and they choose to help push forward new techniques and new innovation, and they work with device manufacturers to come up with new devices or new instruments. I'm so impressed with that, and I want to thank you so much for being one of those people, because that's awesome.
Thank you.
You're saving so many people some hard conversations and some heartache.
It's really a pleasure to do what I do, honestly, and that goes with saying that it'd be tough to do what I do if you don't love it with your heart. You know what I mean? Because as you said, there is physician burnout, especially in my specialty. What I do, especially with the vascular neurosurgical specialty, there's a lot of stress. Sometimes things don't go well. I mean, people can be very sick, and so it can be very stressful. So you really need to love what you do. Now, we've also introduced new techniques and technology here at our institution and in Charlotte. I mean, I've recently formed the Moya Moya and cerebrovascularization clinic, and it's one of a kind around here in the area. I did bring a brand new technology from Chicago with me that my chairman, Dr. Charbel, had developed, that is unique, and that my institution is the only institution in the 6 states around us that has that. It's called Nova. It's an MRI technology that allows us to measure flow in the blood vessels of the brain, and so that really allows me to do my surgeries with cutting-edge technology. That's another example of how you can try to help your patients with the best you have. And so that allows me to do surgeries using the FAST technique, flow-assisted surgical technique, because I have these instruments that allow me to measure flow and make decisions right there and then, either before surgery or during surgery or after surgery, as to how best to move forward with treatment. So there's a lot of examples like that I think are very beneficial to the patient population and moving the field forward.
So I'd like to close with just one final question. That is simply to ask, if you were talking to someone who was considering, maybe they thought plastics was for me, but they were considering neurosurgery as well, what would be your sales pitch to get them to go into neurosurgery?
Well, I mean, to me, it's a no-brainer. I would tell them, do you want to be in the best specialty in medicine or not? And so in all honesty, I would want to guide them with their decision. Number one, the rumor is, and the knowledge is, that neurosurgery is one of the most difficult residency training programs in everything medicine has to offer. So a lot of sacrifice in terms of time, family, health. It is tough. I compare it to the SEALs in the military, or something like that. That type of training.
Yeah.
And I would start by asking them, would you be willing to put yourself through that? It's long, it's 7 years, and there's a lot of hardships, but it's a beautiful specialty. And it is only normal that it requires that much hard work, because you're dealing with the most important organ in the human body. It's the brain and the spinal cord. So would you want to be treated by somebody that had 3 years of training when they're operating on your brain? Probably not. I mean, there's a reason. So I would start off by making sure they understand what they're getting into and understand that it will require, a lot of sacrifice and love to the specialty. And beyond that, it is in my mind and again, I'm biased, the most beautiful specialty. There's a lot to research, a lot of uncertainty, a lot of unknowns, a lot of things that need to be uncovered. Again, a lot of areas. I'm talking about my area, but in functional neurosurgery, there's a lot of brand new devices treat, movement disorders, Parkinson's disease, movement disorders, depression. I mean, amazing things that can happen with a flip of a switch if you put an electrode somewhere. So it's not only my specialty. A lot of specialties in neurosurgery have huge potential in advances and new developments. And so, I mean, if you're wanting to be in a specialty that is moving fast, that is fully hands-on, that has a lot of action in it, does require a lot of hard work and given on your end, then that's the specialty for you.
Well, Dr. Hage, I really appreciate you taking the time to talk to us here on Checking the Vitals. I really appreciate all that you do.
Well, it's my pleasure. Thank you for having me, Todd. That was an amazing interview.
Absolutely. Thank you so much.
Thank you for listening to Checking the Vitals. If you enjoyed the content we provide, please leave us a 5-star rating and review. It really does help people find the show. And make sure you subscribe so you hear our interviews with healthcare innovators every Monday.